Good afternoon, everybody. My name is Eva Watt. I'm the Training and Capacity Lead for NL Support, and I'm pleased to welcome you today to our third webinar. Our guest speaker of today is Dr. Mike Doyle. Mike Doyle is the Director of Research for Eastern Health. He is a health economist by training and is involved in making decisions for new drugs and technologies. I would like to inform you that this session is being recorded. A copy of the PowerPoint slides will become available after the webinar on our website. And please let us know if you have any trouble hearing us. In case you have any trouble, please contact our technical support desk. So let's go back to what is patient-oriented research. Patient-oriented research is about realizing real-world outcomes and engaging patients as partners in research and decision-making. So today, Mike Doyle will start off with an example about how patients can be engaged in decision-making processes for new drugs or treatments. So I would like to introduce you now to Dr. Mike Doyle, our guest speaker of today.
Okay, thank you, Eva. In preparation for today, Eva has asked me to consider an example of patient engagement in the healthcare decision-making. And one of the best examples I could come up with is the Pan-Canadian Oncology Drug Review, which is a relatively new group, began in 2011. And their purpose is actually twofold. One is to conduct thorough evaluations for the evidence of new cancer drugs, and then to provide recommendations to the provincial governments on whether they should provide funding to ensure that drug or not. And the P-coder process actually is twofold. One, once a submission comes in or a request comes in to fund a new cancer medication, the P-coder group actually go out and solicit patient input from actual patients who would have been using that drug as well as comparator drugs. And then they also seek information from clinical studies as well as economic evaluations. And in the second part, I guess, of involving patients in decision-making, they actually include patient members on their expert review committee. So along with the oncologists and pharmacists, economists, and the ethicists, the patient member is also involved in voting on whether a new drug should be insured or not by the provincial governments. So the diagram that actually describes that process is listed here on this slide. So what happens is the submission comes from a manufacturer or a tumor group, and then what happens is P-coder will commission an academic group to review the clinical evidence, and they would look at things like related to the competitor, what is the overall survival, the progression-free survival, post-progression survival, and so on related to the drug and the comparator. In addition to that, they would seek information from patient groups, such as things of how this drug affects their quality of life, their pain, issues around depression and anxiety, and so on, how it impacts their caregivers. And then finally, you see on the right-hand side, what would happen is another group would be commissioned to provide economic evidence, which would include things like the cost per quality-adjusted life year and the impact of adopting this particular medication on the provincial healthcare budgets. And then that information is fed to the P-coder or to the expert review committee. And then the expert review committee, which also includes patient members, would deliberate on each of these drugs, probably for 3 to 4 hours, a discussion amongst 18 people regarding this evidence. And then the patient members, along with the other experts, would vote on whether this drug should be recommended to the provinces to be publicly insured. So what I'm going to do now to the rest of this presentation, the presentation today is really going to focus on 4 things from here on in. One is to introduce health economic terms and concepts. Secondly, to review 3 different types of health economic evaluations and when you would actually use them. And then we're going to actually look at an example of a cost-effectiveness study that was produced by the Canadian Agency for Drugs and Technology in Health. We'll actually go through that study. And then finally introduce critical appraisal guidelines for assessing the quality of a health economic evaluation. And then we'll apply those guidelines to the CAVIS study that we bring forward there under bullet 3. So hopefully at the end of the session you'd have a better understanding of health economic terms and consequences and when you would use these in the decision-making process. So by definition, then, health economics is merely the identification, measurement, and the comparison of costs and consequences associated with healthcare spending decisions. Very rarely is it about saving money. That's often a misconception about health economics, but it's really looking for value for money. I would say in at least 90% of cases, the new intervention or the new drug likely costs a bit more money, but it's probably a little bit better. And what we're looking at is the additional benefit we get worth the additional cost that we're asked to incur. So in the end, we try to answer questions such as, does this technology work? Is it worth it? And should we recommend to the government that they actually pay for it or publicly insure it under the Medicare program? So by way of example then, a cost-effectiveness analysis is a method of comparing the cost and effectiveness of two or more alternatives. So in the CADIS study that we're going to look at in a few minutes, what we actually have is 5 different drugs for sedating patients in the emergency department. And we want to compare and contrast between them and recommend a drug that gives us the best value for money or is the most cost-effective, that we say. In these cases, though, one of the alternatives always has to be standard care. So typically what you're doing at the end of the day, in order to make your reports meaningful, you're making a recommendation about a new drug or technology in relation to the status quo. And so you can say that this one is preferred and it's worth the additional money that's asked to be spent on it. So economic analysis is very much about looking at the incremental gain and relating that to the incremental expense, sorry. The second part of a health economic evaluation typically deals with the budget impact. So we have to be concerned with the budget impact, because what happens in an economic evaluation, it gives us a measure or an indicator of efficiency, but then we have to be able to say, can we actually afford it? So by way of example, if we thought about a new cancer drug, and let's say a new cancer drug could cost $50,000 per patient, and it gives us really good health outcomes in terms of survival and quality of life. So we may deem through the evaluation that $50,000 expenditure per patient is very cost effective. And if the cancer is relatively rare, then only a few patients might be eligible for that new drug, and it might be very well affordable. But if, on the other hand, this was a common cancer and there might be 1,000 patients who were eligible for the drug, then you can see 1,000 patients at $50,000 each would mean that we'd have to come up with $50 million in new monies in order to implement that. The second concern there is with the budget impact is we have to be concerned about silo budgets. So in the healthcare system, many times what we have is a budget within the system for the formulary, for the drug formulary, for the hospital, and even for physician services, among several others as well. And sometimes an economic analysis would require us to spend money, for example, in the formulary. In other words, put a new drug in the formulary, but that might save costs in the hospital services. But the success of the implementation really depends on whether you're able to capture those costs from the hospital. So just by way of example, a few years ago when I worked at the Department of Health, we had an argument from pharmaceutical manufacturers that if we put on new atypical medications for treating schizophrenia, then a lot of patients could be discharged from the Waterford Hospital and could be better treated in the community. And so the budget for the atypical medications went from $1 million one year to $7 million the following year. But unfortunately, when many of those patients were in the community, they weren't appropriately being supervised and so on. They stopped taking their medications because of side effects and so on, and they relapsed and were subsequently readmitted into hospital. So in this case, we actually paid the costs associated with the drugs, but never actually obtained the benefits. So in conclusion here, that decision makers need to be concerned with two aspects. One is the economic impact, which is a measure of efficiency, but secondly, the budget impact, which is a measure of affordability. This diagram on the slide now shows us the relationship between costs and the health status of the population. So what you see on the horizontal axis there is resources spent on healthcare, just the budgets of the Department of Health and regional health authorities. So that's money that we spend on healthcare. And on the vertical axis, what we're measuring is the health status of the population, which is a weighted index really of the patient's quality of life and their length of life. So that's really what we see on the vertical axis is what we want to buy for our patients. It's the health status. And then the curved line, what you see, takes a kind of an increasing slope, then a constant slope, and then a decreasing slope as you carry on with more and more money spent on healthcare. And what it really reflects is that regardless of the amount of money that you spend on healthcare, you're not going to live forever, right? That it does have at some point declining returns. And then if we take this particular graph and we divide it into 3 discrete zones, A, B, and C, what we see in zone A is where we get really good value for money. We spend money in zone A and we get a substantial improvement in the health status of the population. That could be an expenditure, for example, on clean drinking water. That would provide an example in zone A. Zone C, if I move to the other end, would be where we spend money on healthcare and we actually cause harm. So, for example, the overprescribing of antibiotics, the inappropriate use of tests and procedures that subsequently lead to false positive results and then subsequently harm to the patient. So I would argue that the initiative under Choosing Wisely excuse me, has a number of projects that are categorized in Zone C. We're actually spending money on these things and they're hurting the health status of the population. But by and far, the most common area is in Zone B for health economic evaluations. Typically, what you're asked to do here is to consider additional monies for a new drug or technology, and typically you get marginal improvements in health status. And again, you're trying to weigh off, are the additional benefits that you receive worth those additional expenditures? This slide describes that we actually have 3 types of health economic evaluations, and they're actually a ratio with a cost in the numerator and the health effect in the denominator. And so what happens here is that you'll notice that cost is common to all of them, and the next slide will actually describe some common costs that are included in health economic evaluation. So, but the key difference between the 3 is how the health outcomes are measured. So in a cost-benefit analysis, the health outcome, which is included in the denominator here, is actually measured in monetary units. It's not that commonly used in healthcare, so I'm not going to focus very much more on it. It's mostly used in infrastructure projects related to government. So I'm not going to talk much more about that one because it's, like I say, it's not commonly used in healthcare. But the other 2, B and C, are the cost-effectiveness analysis and the cost-utility analysis. In a cost-effectiveness analysis, the health outcome is specific to a particular disease, but unfortunately you can't make comparison across different disease categories. Whereas in a cost-utility analysis, the health outcome is actually going to be converted into a quality of life and length of life equivalent or index. And then if you do that for multiple diseases, you can actually compare and contrast different interventions and drugs across different denominators or different procedures. And what I'll do is show you an example here which will make it hopefully illustrate it a little bit more clear. So as you noticed from the previous slide, cost was common to each of these types of evaluations. It includes all relevant costs regardless of who pays them, but is influenced by the study's perspective. So ideally, a health economics evaluation would be done from a society perspective. And in that case, it would actually include the cost that the patient incurs. But many times you'll see a health economic evaluation only done from a third-party payer perspective or from a government perspective. And in those kinds of cases, it would actually exclude any cost that the patient incurs. So common costs that we're going to see in our health economic evaluation is going to be obviously the pharmaceutical cost, the pharmacist dispensing fee, the physician consult fee, hospital costs if a patient is admitted to hospital due to an adverse event, then it would be the average cost of a day in hospital. And as I mentioned, the cost to the patient in this type of analysis wouldn't be included, which is an obvious limitation of it. So the first type of health economic evaluation we're going to look at is the cost effectiveness analysis. So by definition, it's used to compare at least two options for achieving the same goal. So in our case, we're actually going to look at 5 different analgesics or sedatives used to sedate patients for painful procedures in the emergency department. Now this analysis becomes relatively easy if you can demonstrate that the 5 drugs are actually equally efficacious. In other words, if we can prove clinically that the 5 drugs are of equal benefit, then of course in that case we would just pick the lowest cost alternative. But that doesn't happen very often. Typically what you see is that the newer proposed intervention is a little bit better, but it costs a little bit more. And we're trying to weigh off that additional benefit and see, is it worth the additional cost that we're actually asked to pay. So in a cost-effectiveness analysis, the final effect or the clinical effects are measured as final outcomes and are specific to the condition. The next bullet is particularly important. So as way of an example, if we were looking at a new cardiac drug, the outcome in the study might be the incremental cost per heart attack prevented. If we were looking at an antibiotic, the outcome might be the incremental cost per sick day avoided. If we were looking at a new diagnostic test, for example, the outcome might be the incremental cost per specific case detected. But because the outcome in this case is different across those different categories, you can't cross-compare them. Right? So, for example, in this case, you could use a cost-effectiveness analysis to compare two new cardiac drugs for the same condition, or two cardiac drugs for the same condition. You could use it to compare two antibiotics for the same infection, or two diagnostic tests for the same outcome, but you can't cross-compare between the three. And that's the key limitation that's mentioned here in the last bullet, that the health outcomes are only one-dimensional and specific to a condition. In a cost-utility analysis, it's used when health outcomes have two or more dimensions, and typically those dimensions are quality of life and life expectancy. And again, as we mentioned before, those are the two key things we want to buy for our patients. When we present at the healthcare system, we want to know, is this drug or technology going to make me live any longer, or is it going to make me live any better? And what we do in a cost-utility analysis is we take the health outcome and we convert it for extended life that we get. We convert those extended years into a healthy year equivalent using various techniques, and I'll get into an example of that in a minute. So there's a number of direct and indirect approaches for taking the health outcome and convert it into a quality of life score. And judgments are typically made by samples of patients or the general public. So in the end, then, the quality is going to be a weighted measure of the two factors, the quality of life and the length of life. And the key advantage of a cost-utility analysis is that once you derive a quality, you can derive a quality, for example, for a new cancer medication. You can derive it for a new antidepressant. You can derive it for a new hip replacement procedure. And then once you've done that, you can cross-compare between the cost of the new cancer drug versus the new antidepressant versus the new hip replacement procedure. So what we do here, one way of doing this is what we call the visual analog scale, and that's probably the easiest one. We have that scale on the screen there now. And what you see on the far left side is a value of 0, which reflects death. And on the far right side is a value reflects full health, which is 1. And so what we do is we take each year of life that's gained by an intervention and scale it back by the quality of that year. So let's say, for example, a new cancer medication comes about, and that new cancer medication allows a patient to live 2 years longer, but because the patient in that 2 years suffers a fair amount of pain and discomfort, say anxiety and depression, and they're unable to do the usual activities, the patient may actually report on the scale that that's the equivalent of 0.5 in terms of a quality of life equivalent. So if the drug was able to extend their life by 2 years, but the patient only valued that life at 0.5 on the scale, then that would be the equivalent of 1 quality. And then if we said that, well, over those 2 years we paid $150,000 in additional healthcare costs in order to provide that drug, then we would say the incremental quality is $150,000, right? So the cost per quality was $150,000 in this case. And of course we can compare that between different drugs and technologies across a number of different health conditions. So the next slide is telling us, where do these quality indices actually come from? And as I mentioned, there's a number of direct and indirect approaches, and then just for time limitations, we'll talk about a common one, which is the EQ5D. So the EQ5D is an actual validated survey of about 3,000 people that combines 5 different dimensions of health and 3 levels within each dimension. So the levels of health would include things like the patient's reported level of mobility, their ability to do self-care, usual activities, and the amount of pain, discomfort, anxiety, and depression that they feel. And then for each of these dimensions, the patient would report whether they have no problem with that, some problem, or a major problem. And then all of these survey responses are calibrated to an equivalence quality score between 0 and 1. And so then what we're interested in, excuse me, if we have a new intervention, what we're interested in is what is the quality score before we provide the intervention, and what is the quality score after the intervention, and of course multiplied by how long they live with that condition to give us the total amount of qualities achieved. So there are some limitations obviously as well with a cost utility analysis. This is not an exact science. There's at least a half dozen ways of calculating these quality scores, and if you apply the same condition to each of these approaches, you get slightly different responses. There's also a lack of sensitivity for less severe health problems. So they work quite well for things like cancer and hip replacements and knee replacements and depression and things like that, but not so well for maybe the common cold or much less health problems. There's also a lack of consideration of the impact of the disease has on caregivers and family members. So I'm actually going to stop there for a minute now and just wondering if there are any questions before we actually get into the example of a cost-effectiveness analysis. Okay, it looks like there might be a couple of people typing, so we'll just hang on for another minute. Okay, it doesn't seem to be any questions. We will have another opportunity in a few minutes, actually, to pose any questions. So what we're going to look at, well, so far what we've done is we've introduced different health economic terms and concepts, and we've looked at 3 different types of health economic evaluation: the cost-benefit analysis, the cost-effectiveness analysis, and a cost-utility analysis. Now what we're going to do is look at an actual example of a cost-effectiveness study that was completed by the Canadian Agency for Drugs and Technology in Health. And what it's going to involve is a comparison of short-acting drugs or agents that are used in the emergency department to sedate patients for painful procedures. So by way of background, what we have at the time when this study was introduced, we had 4 new short-acting drugs for procedural sedation. And I hope I do the pronunciation right, but propofol, ketamine, etomidate, and a combination of a ketamine and propofol cocktail, I guess. And they were compared with a traditional therapy that was commonly used, which was an opioid benzodiazepine combination. And as I mentioned, they're used in the emergency department for painful procedures such as bone fractures, major joint dislocation, and some cardiac procedures. So essentially what we have is 5 drugs for doing the same purpose. And what we want to do is compare and contrast between them and choose the one that's the most cost-effective. So the argument from the manufacturers of the new drugs is that they reduce procedure time. So from the time the patient presents in the emergency department, we'll say with a dislocated shoulder, and from the time they can be sent home, they argue that their new drug will sedate the patient quicker. They will have a probability of a greater success rate and less minor events or minor adverse events associated with the drug. So if you can reduce the procedure time, then they argue that the costs associated with physician time, nursing time, costs associated with the hospital, and any adverse events would be lower with the new drugs. So what the researchers need to do at this point is examine the expected cost of the entire episode of care, from the time the patient presents at the emergency department until they go home, and actually 6 or 8 weeks later, to ensure that there's no follow-up adverse events. So what they do is they develop a computer model of how the patient would transition through the emergency department. So they need to know, for example, the combination of things that can happen. So what we can say here is that we know when you present at the emergency department with a dislocated shoulder, the first attempt to put your shoulder back in will either be successful or unsuccessful. And fortunately, if it's not successful, you don't get to go home with your shoulder dislocated. You actually get another sedating drug and you get the procedure done a second time. So you keep at it until you actually will get your shoulder back in place. But even despite that, what you may find is that the patient may suffer an adverse event that requires them to be hospitalized, which is relatively rare, but it can happen. The patient can suffer an adverse event that doesn't require hospitalization, and in fact it's resolved in the emergency department. And then finally, in the best case scenario, the procedure is successful, the patient doesn't suffer any adverse event, they're not hospitalized, and they can go home. So what we have is 6 potential clinical pathways for each of these drugs, and the authors will follow the patients for up to 8 weeks. Okay. So in each of these cases, what we need to know to put the information that we need to put into the model, what would be the probabilities for each of these clinical pathways, and what would be the associated costs for the clinical pathway. So the costs are going to be associated whether the treatment is successful or not, how much time the physician, the nurse, and the paramedic have to spend with the patient, how long it takes the patient to recover, and of course what are the costs associated with buying the various drugs that we're asked to consider. Costs can occur across a number of settings. They may occur in the emergency department. What if the patient is hospitalized? There's obviously going to be a cost in the hospital. The physician is paid both in the emergency department, the hospital, as well as their family doctor if they suffer an adverse event. And there may also be visits associated or revisits associated with the emergency department, and the patient may be asked to purchase outpatient drugs. The final bullet here on this slide talks about the distinction between decision nodes and chance nodes, which we're actually going to see in the model in a minute. A decision node occurs when the healthcare provider, typically the physician in this case, makes a decision to provide one of the 5 drugs. So that would be a choice that the physician makes. He or she chooses one of the 5 drugs to provide. And then the chance node will indicate that whatever happens after that drug is prescribed or administered, everything that happens downstream from that will be based on probabilities that are obtained from the clinical literature. So I can illustrate that if you look at the next slide. And this is the actual analytical model that the researchers built to describe how patients go through the emergency department in this case. So and it's actually going to be on 2 slides just because of the size of it. So we start from the left where a patient presents at the emergency department, for example, with a dislocated elbow or a dislocated shoulder or requiring a cardiac procedure. And you see that blue square there, the small blue square there almost in the middle of the screen. That's actually a decision node where the physician has to decide whether they're going to provide the patient with one of the new fast-acting drugs or they're going to provide them with the existing opioid benzodiazepine combination that they traditionally use. And then as you move a little bit more to the right, you see another blue square. This is where the physician in this case now has to decide, well, I've already decided that I'm going to give them one of the new drugs. I now have to decide which one of the new drugs I will administer, whether it's ketamine, propofol, etomidate, or that combination of ketamine and propofol. And then we carry over to the next slide, which is again moving from the left. So these are the things now, the 6 things that can actually happen to the patient, right? The pathways that can occur to the patient. So first of all, the patient has been sedated, and now you will see that the procedure will either be successful or unsuccessful. And both of these will have a probability associated with them that came from the clinical literature and as well from expert opinions and things like this. So for example, the probabilities in this case have to add to 1. So if there's a 90% chance that the procedure is successful, then of course there's a 10% chance that it isn't successful and the patient has to re-administer and try and have their bone put back in place. And then despite that, the patient may be hospitalized. They may suffer an adverse event that doesn't require hospitalization. And they may suffer no adverse event and no hospitalization, of course, can go home. So the best outcome for this patient would be the case where the procedure is successful and they suffer no adverse event and suffer no hospitalization or experience no hospitalization. So the input that has to go into this model is both the cost of these outcomes as well as the probability that it happens. So for example, if the patient is hospitalized, the cost of that might actually be $5,000. But fortunately, there's only a 1% chance that that would actually occur according to the literature. So what we do in this case, we determine the expected cost per patient, which would be the 1% times $5,000, which would give us an expected cost of $50 for hospitalization. And so that's what we do for each of these cases, is we're multiplying the probability something will happen times the cost if it does happen. Then what we do is we roll back the table, or the tree if you like, and we look at all the different drugs across the top there. So you see the 5 different drugs, and then on the left-hand side what you see is the breakdown of the different cost categories. And then looking at the information, we see that propofol gives us the lowest total cost relative to all of the comparators, and particularly the standard comparator. And we actually, when we compare propofol to the standard therapy, what we're seeing is that the total cost of this drug, of the total cost of the episode, if you like, is only about 1/3 of what the standard cost would be. So in this particular case, we would say that propofol is the most cost-effective, and that's, of course, the one that we would recommend. Now, if we carry this analysis a little bit further, so this one is pretty straightforward. Propofol is obviously the clear choice in this particular instance. If we carry the analysis a little bit further and assume for a second that there was only 2 comparators, let's say Ketofoil and the standard therapy. And in this case, what we would see is that Ketofoil is actually only about half the cost of the standard therapy. So again, we would conclude that Ketofoil is the most cost-effective or preferred option or dominant option in this particular case. But interesting enough here, if we looked at the budget impact, what could happen here is that the pharmacy would look at this and say, you're asking me to buy a drug that's 7 times the cost of the standard therapy. So the Ketofoil would cost $22 per patient, whereas the standard therapy is only $3 per patient. But the savings to the healthcare system would actually occur in the hospital budget because of the lower rate of adverse events and admissions to hospital and so on. So the director of the pharmacy program is going to argue that there will be a budget transfer from the hospital budget to the pharmacy budget in order to pay for that additional cost. But unfortunately, in some of these cases, the pharmacy or for example, the hospital budget might already be over budget, and they say, well, we don't have the money to actually transfer from one budget to another, or from the hospital budget to the formulary budget. And so in this particular case, even though Ketofoil on paper looks like the most cost-effective option, if we aren't able to make that budget transfer, we actually may have incurring additional costs. So I'll actually stop now at this point, because we're going to enter into the third phase, if you like, of looking at. We're going to enter the third phase of looking at the critical appraisal of this particular study. So we have a couple of questions here. One is, who determines the value? What happens when they determine, I'm assuming that's the value of the input costs in terms of physician fees and pharmacy fees and drug costs and so on. They would actually come from published evidence. So for example, the doctor's fee would come from the MCP guidelines, or in Ontario it would be the OHIP guidelines. The drug costs would be the actual costs that are paid by the formulary or by the director of the drug program in order to provide them. So those are input costs that would come from various sources, and then sometimes expert opinion. And then what we're going to see, just to jump ahead a little bit in the critical appraisal stuff, we're going to see that what the authors will do will be to start to vary those costs by 5 and 10% and see does it have any change in the model or in the conclusions that we come from our analysis. So when we do a critical appraisal of a health economic evaluation, really what we're trying to do, we ask a series of questions about the study. And the series of questions are essentially trying to get at 3 factors. The first one is, do we believe these results are actually true? Do we believe the results are true? Secondly, do we think these results are significant enough to warrant us to want to change clinical practice. So if propofol is the preferred option, is it that much better than the standard therapy that we would want to go around to all the emergency departments throughout Canada and convince them to use propofol over the standard therapy? And then thirdly, from a perspective of Newfoundland and Labrador, do we think that this study, which many of the inputs came from Alberta, do we think a study that had input variables from Alberta could be applied to Newfoundland and Labrador, and would we expect the same results there? So the first question we look at is, was the economic question properly posed? So in this particular case, what I did was I obtained the technical documents, or background documents, if you like, for this published study, and then I went into them and tried to answer all of these critical appraisal questions. So ideally, health economists are concerned about, does the study look at the appropriate population? What is the intervention that they've described? What is the appropriate comparator in this case? And what is the outcome, or the clinical and both health economic outcome that we're looking for? So we refer to this as the PICO, the PICO inputs here. So when I actually looked at the technical documents, this is the research question that the authors were attempting to answer. So what is the cost effectiveness of using short-acting agents compared with traditional therapy or an opioid benzodiazepine combination in adults presenting at the emergency department for procedural sedation? So the population in this case is adults presenting to the emergency department for procedural sedation. The intervention is the use of short-acting agents. The comparator is the opioid benzodiazepine combination. And the outcome of interest is cost effectiveness. So it looks like in this particular case, they did pose the correct health economics research question. The second question is, were all the alternative programs adequately described? So ideally, in a health economics study, when you read the methods section, there should be enough information there that would allow the reader to replicate the experiment if they so choose. So from a cost perspective, you need to know who did what to whom, where, how often, and how much were they paid. In this particular case, there was a very detailed description of the clinical practice. The authors had described thoroughly the 6 stages from the time the patient presents at the emergency department until they're discharged. There was a thorough description of the various staff that were present, such as the nurse, the paramedic, and the physician, and what each of their roles were. They also supplemented that information with a time and motion study throughout emergency departments. I believe that was done in urban Alberta. And despite this, they determined that there was a wide variability between urban and rural emergency departments. So there's different drugs used. They found the different traditional drugs are more commonly used in rural emergency departments, and less, and the newer drugs were more commonly used in the urban centers. And we'll come back to that point again in a few minutes. Thirdly, has the program's effectiveness been validated? So as we said in a cost effectiveness analysis, what we're measuring in the numerator is cost, but what we're measuring in the denominator is the clinical effect of the drug in this particular case. So we get that information from the clinical literature. And so if the information that's used in the denominator, if the clinical information that's used in the denominator is not of very good quality, then by definition the health economic evaluation won't be of very good quality. So it's important for the authors, the best they can, is to include properly designed randomized controlled trials to be included in the denominator. So in this particular case, when I looked through the technical documents, what I found was that there was a very detailed literature search strategy using multiple databases. The authors had actually contacted the manufacturers of the 5 different drugs and seeking any unpublished or ongoing studies, information from the gray literature. They developed a study screening protocol to abstract the necessary information from each of the studies. And then they had actually used 2 independent reviewers to go through the process independent of each other, and then they ranked the level of agreement between them afterwards. So in the end, the study quality was actually assessed using multiple approaches, and they deemed that the input studies, the clinical studies, were of moderate quality. And because of that, then they also used a National Emergency Department survey, time and motion study, and had contacted various health authorities throughout Alberta for additional information. So in this case, it was a very thorough approach to screen and assess the quality of the input information used in economic analysis. Fourth question deals with, were all important relevant costs and effects identified? So ideally it would be the study, if it was done from a societal perspective, would have included cost to the patient and others. And we know in this particular case it didn't actually include the cost to the patient. It was just the cost that the healthcare authority had incurred. And as well, we'd be interested if information was available on morbidity and mortality related from the patient's perspective. So in this particular study, they had actually also excluded capital and overhead costs. Just because the episode would only occur over an 8-week period, it wouldn't have any impact on the capital and the size of the hospital and the overhead costs and so on. As I mentioned, they had taken the study from a Ministry of Health perspective, which would have excluded any cost to the patient. And in this particular case, they had used Canadian quantities but Alberta prices. So the cost, for example, per hour of the nurse, the cost of the physician, the cost of the paramedic and so on would have come from Alberta. And now we'd have to be concerned if we were applying the study in Newfoundland and Labrador, we'd have to have some level of comfort that that those prices reflected what we actually pay for those providers here in this province. And if they're different, then of course it affects the size of the benefit that we would achieve here in this province. Number 5, was an appropriate analysis carried out? So again, the type of analysis that we do depends on the economic question. We've discussed that we had a choice between 3 different types of analysis: the cost-benefit, cost-effectiveness, and cost-utility analysis. In this particular case, they did do a cost-effectiveness analysis, but because the study impacted things like patients' pain and satisfaction and so on, ideally we would have preferred a cost-utility analysis, but there just wasn't enough clinical information in the literature regarding pain and patient satisfaction with each of those types of drugs. And we can assume that the patient, relatively, that procedure was over within a few hours, that whatever discomfort they experienced would have subsided afterwards. And then the final question is in relation to the presence and magnitude of bias. So I alluded to this a few minutes ago. What happens in an economic analysis is that we input a lot of information. For example, we inputted information about the cost of the drug, the cost of the nursing times, the physician fees, the probability of adverse events, and so on. And so now what we do, or authors will do at this particular point, is start to input or start to change those inputs by maybe 5 or 10%, both above and below the baseline value, and then they run the model. And so what we see is they do what we call a one-way and multi-way sensitivity analysis. So start to run the model multiple times by changing one variable at a time in a one-way analysis, and in a multi-way one, they're changing multiple input variables at the same time. And so what they're doing is continuously running the model, trying to find a combination of input factors that might make your decision be another drug other than propofol. But in this particular case, no matter how many times they ran the model changing those input variables, propofol always remained the dominant strategy. And what we mean there is that propofol always came up, or was always concluded that that was the least expensive option, and it had the improved health benefits over the other comparators. So we would say that we were quite confident in concluding that propofol was the choice, the best choice. And then we move to the potential budget impacts. So we're saying, is this really the benefit that we get from changing the use of an opioid benzodiazepine combination to propofol? Is it really worth the effort to do this? So in Canada, approximately 1% of emergency department visits require some sort of procedural sedation. PSA just refers to procedural sedation. And so the authors estimated that if you were to substitute propofol for the comparative therapy, that you would save somewhere between about 34 million to about 60 million annually across the country. Now the savings might be overestimated a little bit because by the time the study was completed, propofol was actually commonly used in the urban centers. And the older medications are still widely used in the rural areas. And the reason for that is that some physicians in the rural areas were concerned that the patient may rarely suffer an adverse event related to procedural sedation that requires the services of an anesthetist. And in a rural area, the anesthetist may not be readily on hand. So they would continue to use the traditional therapy. So what we're seeing here is that even though propofol was deemed the most cost-effective option, there might be some practical implications that might limit its uptake. So in concluding then, what we see is that these new short-acting sedatives induce sleep sedation faster and more reliably over the traditional agents. The adverse events that were experienced were not considered that serious and responded to simple measures in the emergency department. The data in this case came from multiple sources, including clinical reviews, patient surveys, expert opinion, and so on. And despite that, propofol always remained the dominant strategy, that it was the lowest cost option and provided the best clinical benefits. Okay, I think we have some questions there. You might be going to, I think we've answered a couple. What other outcomes would you suggest for evaluating antibiotics apart from sick days? Well, I was involved in a cost-effectiveness analysis a number of years ago, looking at 3 different fluoroquinolones for looking at things like prostatitis and urinary tract infections. And we searched the literature at the time, and that particular outcome was the one that we chose. I can't specifically recall other ones, but what you looked at, people had those conditions, they might be off work, which would be lost days of work or things like that due to the symptoms of a urinary tract infection or prostatitis. So that could be something, another potential indicator. We actually chose sick days because what we decided in the end, or what was found from the study, was that a new antibiotic actually increased the cost per day of day avoided of this particular outcome, and it turned out to be $4 a day. So the question becomes, would you pay an additional $4 a day to avoid the symptoms of prostatitis or urinary tract infection? And even though in that particular case it was more expensive, it was also deemed cost effective. That low level of cost per day was deemed beneficial to society. But I would say another one might be a number of days off work or work days lost due to an infection. So the second question is, do they look at the result down the road of using an opioid? And that's a good question. Economic analysis have to be long enough to capture all relevant downstream events, clinical events, as well as costs. So in a cancer drug, for example, when we look at a health economic evaluation for cancer drug, it actually might carry on 10 or 15 years, right? So a patient might be living with a chronic cancer for a long period of time. Many times, obviously, the clinical studies, the clinical trials won't continue that long. So what the authors will do is extrapolate the results from the time the trial ends, say at 18 months or 2 years. They might extrapolate the results statistically down maybe 5 or 10 years or more. And so ideally, that's what should happen, is that the results of the study would carry, many times in cancer, they actually go until the patient dies. And then what you do is you discount the cost back to present day value. So you discount the expenses that you incur, and you discount the benefits back to a current day or $2016 equivalent values, if you like. So the next question is, what is the big problem of doing the transfer of fund between the different groups in healthcare? For example, between the pharmacy and the hospital. Okay, so what happens in this example, and as mentioned with the procedural sedation, what they do when they do the economic analysis, they have to look at the average cost. So if a patient, for example, was admitted to hospital for 1 day, the average cost of a day in a hospital might actually be $1,000. But if that patient doesn't actually present to the hospital doesn't actually save that money, because there were no nurses laid off, there was no technicians laid off, there was no porters laid off, there was no one actually displaced in the process. So even though on paper the average cost of a day in a hospital is $1,000, just because that doesn't occur doesn't mean that the administrator can grab the $1,000 and transfer it to the pharmacy budget. So that's the particular problem here. So the efficiency gain when you do these things sometimes is just that you're able to admit another patient and put more throughput through the hospital, but you can't actually capture the budget impact. Right? So I hope that actually covers that one. Do you use benchmarking in the evaluation process? For example, costs in other geographical locations versus Newfoundland. Yeah, that would be actually included in the sensitivity analysis. So the study might have been done, in this particular case it was done from an Alberta perspective, but then the authors might look at it, and even someone in a local area who wants to apply the study would then look at the physician costs, as an example, and the nursing costs and pharmacists and so on, look at them in the province that hosted the evaluation and compare them to the other jurisdictions. And let's say there was a plus 5, 10, 20% difference between them. They would accommodate for that in the sensitivity analysis and run the model again. So. Okay. Any other questions? I feel like an open line host here. I have a caller online for you. Any further questions? Okay. Well, thank you very much then.
One other question.
Oh, sorry. There's one other question. What is the role of the drug companies? Sometimes the drug companies are asked to provide for information. I think of an example with the Pan-Canadian Oncology Drug Review. So the role of the drug company in that particular case is that they make the initial submission that they're asking for their drug to be listed on the formulary and to potentially replace a comparator. So they will provide the additional information, and then it's from PCODER's perspective then to critically appraise the information they're completed. They take the data that's provided to them, they rerun the models and so on and come to their own conclusions. So it's typically the role of the drug company to start the process, if you like, to make the request. And obviously, if it's in their financial interest, they will be the first ones to initiate that. Sometimes it comes from tumor groups, just clinicians believing that one particular medication is better suited than another and has less side effects and things like that, or might be more efficacious. But typically, just to answer your question, the role of the drug company in this case would be to start the process. And there's another question there. I'm looking at evaluating cost effectiveness of using telehealth for client services versus traveling for the service for either healthcare providers or clients. Do you have any suggestions of the type of evaluation for this? So in this particular case, I would think about the PICO model. So what is the population that you're looking at in this particular case? It's patients with certain conditions, I would imagine, in rural areas. What is the intervention in this case? It would be the telehealth service. And then you would want to compare that to the existing approach that they use. And then I would think that the outcomes of interest might be the difference in health of the patient. It might be things around the cost to the patient, and as well as the cost to the healthcare system. So those would be, I would just think off the top of my head without looking into the literature there, that those would be the kinds of factors that you'd want to consider. So the main thing I would suggest, though, at this point is to consider the actual research question, the PICO approach, if you like, the population, the intervention, the comparator, and then the outcomes, both from a patient perspective in particular, and as well from the healthcare system perspective.
First of all, thank you, Mike, for this interesting presentation. We will be in the room for another couple of minutes, so if you have any other questions or comments, please feel free to share them in the chat box and we will get back to them. I would just like to let you know that we have a next webinar coming up this month. This is November the 24th, and this webinar will be about grant writing. So we will be talking specifically how to write a grant for patient-oriented research projects and where to look for funding as well. So save the date and you can register now on Eventbrite. We will also share by email with you a little survey. We would very much appreciate if you would fill out this survey. Every single feedback or comments are more than welcome. So thank you so much for attending today, and please let us know if there are any other questions. There's one question: will the November 24th event be available online after the event? Yes, all the events, all the webinars will be available on our website in a PowerPoint presentation, and some of the recordings will also be shared on our Facebook post. So please keep an eye on our Facebook and our Twitter account. I will share this as well with you by email. So you can always have a look at the webinar slides. Okay, thank you so much.